some practice scenarios. Camera's just not working on here, so figuring that out. Okay. Okay. Talk through some things here. So why do we delegate? What's the purpose of delegation?
To get stuff done.
Yeah, to get stuff done. Why may we not delegate?
Because we're lazy.
Because we're lazy.
Because you don't
So-
feel like doing that.
So why we may not delegate?
Yeah.
Because we don't feel like doing it, okay? So if we are lazy and we don't feel like doing it, we don't delegate, what's gonna happen?
It's not gonna get done.
It's not gonna get done, okay? How do you guys feel about entering practice and being able to delegate?
I feel like it's important to, form like solid relationships with those who you're delegating to, because if you trust them, know that they're gonna do the right thing, follow through with it, it's easier than, say, a stranger.
Yeah, so once you kind of have those formed relationships, it's easier because you know their abilities and that they'll do things how they're supposed to be done. How many people in here are very much type A and have a specific way that they like things to be done? Okay. That might be another reason why we don't delegate. So we have the 5 rights of delegation that we'll talk about here shortly. What happens if we do not follow those 5 rights?
Can cause harm.
Cause harm. Ultimately, you know, we're looking at our client safety, client outcomes. So we talked earlier in the semester about like assignments. So what's the difference between like delegating and assigning? So delegating and doing assignments, what's the difference between those two?
When you delegate, you hold responsibility for the outcome, or when you assign, you're passing it on.
Yeah, so assigning, I'm transferring that responsibility. So if we're thinking, you know, we talked about the charge nurses making their assignments for the shift, they're transferring that responsibility and accountability to the nurse or, you know, the LPN that's going to be caring for them. So someone else on the healthcare team has responsibility. We're delegating, we still have that responsibility and accountability. So we still are accountable when we are delegating. So we're accountable for that client, we're accountable to make sure that that task that we have delegated gets done, that it gets done correctly, that it's documented correctly, so we can retain accountability. So here I'm gonna pull up an image of delegation model here. So this is a photo of the models obtained from the National Council of State Boards of Nursing. So when we are looking to delegate, we should be following our delegation model that we have here. So you can kind of see what the responsibilities are. So we have our employer and nurse leader responsibilities. So we're identifying a nurse leader, determining nursing responsibilities that can be delegated. So that's kind of looking at the policies side of things. So the licensed nurse, that's where we are. We determine the patient needs and when to delegate. Ensure availability of the delegatee, and then evaluate those outcomes and maintain accountability. And then the delegatee responsibilities accepts activities based on own competence level. So if they don't have the skills and the knowledge, and we'll talk about our 5 rights of delegation here in a moment. If they don't have those skills and that knowledge, they can say that they're not comfortable doing that, because they need to, know their limitations and be accountable, and then you could take the time to teach them how to do that, show them how to do it. Maintain competence for delegated responsibility. You know, when you start a job, you have all of your checklists that you have to go through to show competence in certain things. And then maintain accountability for the delegated activity, so they're accountable to carry out that delegated activity. So that's just kind of our delegation model there. Again, like we said, it's all for that public protection, ensuring those positive client outcomes that we have. So what are the delegating factors that we need to consider as we're going through here? So what do we consider?
Scope of practice.
Yep, scope of practice. So kind of thinking about their experience that they have there. What else? So what are some of the things up there that maybe kind of go along with the delegating factors that we've talked about?
The circumstance in which you're delegating to.
Circumstance. Kind of like you guys said, like their scope of practice or their education and knowledge. And then looking to like, based on own competence level, so knowing their knowledge of that skill or that task. So similarly to us, we want to think about, are they able to do that or not? Is it within their scope of practice or is it outside of their scope of practice? So like we have here with the employer nurse leader responsibilities, you know, talking about if there's, it's those policies and procedures within their scope of practice there, so we need to consider that, because we're not gonna delegate to a PCT to go do a med pass for us. That's outside of their scope of practice. So what's in the bottom here, that's always important with everything that we'll talk about next week. Communication. Do you guys feel comfortable communicating like to your like PCTs or another nurse to complete a task? Or maybe depending on who it is. Okay, so we have different things that we have to. So like we said, you know, demonstrated competence in that task. You know, we all have our competencies that we have to mark off that we are able to do. You need to demonstrate it, you know, so many times. So as you guys are graduating and starting work, you guys will have to do this as well as nurses. So your preceptor will sign off on all of these things here as we're going through. So we have 5 rights of delegation. What are those 5 rights of delegation that we have?
Right task.
Right task,
Right circumstance.
right circumstance,
Right person.
right person,
Right supervision.
right supervision.
Right direction and communication.
Yep, so what, right direction and communication. So again, we need to, make sure that the person that we're delegating to has the education and experience to be able to complete this task. And do they have the knowledge and skill of the task? Is this something that they've done before and that they feel comfortable? Or is it something that maybe this time you'll need to demonstrate to them how to do it? So again, thinking about the level of critical thinking, communicating very clearly about what you need to have done. So what else should you include in that communication? Bless you. So what you need to have done, what else should you include?
How to do it.
How to do it,
Like a time frame.
time frame. Cause if we're like, oh hey, can you go get vitals for me? I'm like, do you want it now? Do you want it in 3 hours? You know, like, so that time frame. What else will we want them to do?
Like report back if it was done.
Yeah, report back. I know maybe with like vitals, I know like a lot of our PCTs with experience, recognize those abnormal vitals, but being like, hey, if the blood pressure is above this, please let me know right away. If the heart rate's above this, please let me know right away. We'll want them to document what they did. And then, yeah, like I said, we might need to oversee what they're doing, so we might need to supervise them. Then it might come a time when we don't actually need to fully be in there with them while they're doing it. So I think it can get a long ways with our delegatees, like our PCTs and everything, if we empower them, if we're working as a team. Because I'm sure you guys have been in experiences or in situations, even as a student nurse or as a PCT, where there might be a nurse or someone on the healthcare team that might just kind of look down on you just because of your position. So it's important to empower them and remind them that we're a team and we're all there for the same goal. And you want to be approachable and know that they can come to you to ask questions. Because I think through your experience, you probably all know that if you are willing to help and be open, people are going to be more willing to help you and be open. And so then your role is to go ahead and make sure that all of that gets done, that it's documented, that it gets done correctly, because remember, you still maintain accountability for that client. Okay. So we kind of talked a little bit about some of this. When we were looking at scope of practice and everything, so what are things that we can delegate to that practical nurse?
Trach care.
Trach care.
NG placement, or if it's still in the right place.
Okay, so the NG assessment, or like NG confirmation, after we have done that.
Yeah.
Oral meds.
Oral meds. What else? So along with oral meds, are there other routes that they can do?
Is anything but IV?
Yeah, pretty much anything but IV. But like anything but IV. So again, knowing what our person's scope of practice is. You have a Foley that needs to be inserted. Who are gonna be delegating that to? LPN, yep. I know that for the longest time, we did not see LPNs in the hospitals as much, but in a few weeks, we'll be talking about different care models, and so a lot of hospitals now are going to a different care model that does include LPNs in the hospital. Primarily, I think that's to address the shortage that we have of nurses. So you will be probably working with LPNs. Can LPNs do assessments? They can do the monitoring of everything, but they can't do any of those initial assessments or changes.
Can they do assessments after you've done
The initial, they cannot do the initial assessment, or an assessment would change of status, but like, yeah, any of those, like just checking to see if everything's baseline, monitoring. But if they recognize something, they need to be getting the registered nurse there. Yep. Trach care suctioning, yeah. We kind of talked about that reinforcement of education. The LPN cannot do that education, but they can do the reinforcement there. about our assistant personnel, like our unlicensed assistant personnel, our techs, things like that? What can they do?
Like daily cares.
Yep, so our ADLs,
Vitals.
vitals. EKGs. Blood sugar, checks. So ADLs, what can we kind of include with like those ADLs?
Hygiene,
Hygiene, feedings, help get clients dressed. They can ambulate our clients, do repositioning.
They can use transfer equipment too.
Transfer equipment. Can't see my brain. Change positions. Repositioning. There it is, about the feeding. So I just want to remind everyone that all of this is within our scope of practice as well. So you will be expected to do these things as a nurse. Like I said earlier, we are a team, and it's never, shouldn't be the mindset of, well, I'm the nurse, I don't need to do that anymore. This is all within our scope of practice. We all need to be doing these things, because remember, we all have the same goal of protecting that patient, having those positive outcomes as we're going through. So errors in delegating, talk about under delegating. What can happen when you end up under delegating?
You could get overwhelmed and make a mistake.
Get overwhelmed, get too busy, make a mistake, something might not get done. So like some of those factors that we talked about, we might not trust the person that we're working with to do it correctly. We might have a specific way that we want things to be done and don't trust other people to do it the way that we would do it. And sometimes it can just be difficult to give up control. What will be some errors with over delegating? What happens if we over delegate?
they see you sitting there at the nurse's station and get bitter.
Yep. We overburden others for filling up other people's plates. And then we're just sitting there doing nothing. As a nurse, when I saw other nurses doing that, it drove me nuts. So yeah, then people aren't gonna wanna be as likely to help you, and it kind of loses that team mindset. There were plenty of times when I'd be at work and, you know, when our techs were running around, you know, doing like lab draws, they would have, you know, special training to do lab draws, maybe taking patients to x-ray, doing all sorts of different things. And then the nurse would go up to them and ask them to do something, and then they would go and sit down and just be staring at their phone. It's not even like they were sitting down documenting and doing stuff that needed, you know, stuff that we still do need to do. They're just sitting there on their phone, doing nothing. So yeah, you're not gonna get as much help if you continue to over delegate. So yeah, I would always kind of approach my techs and was like, hey, can you do this for this client while I do this?
Mm-hmm.
So kind of showing like, hey, I'm busy doing this, that's why I can't do this, otherwise I would. Plus through, you know, like you would gain those relationships and they see like, okay, they're more than willing to help out and jump in. Like, oh, like they're willing to go get vitals on that client even though it's not theirs, that type of thing, you know, that team aspect, seeing that. What happens if we do not properly delegate, if we do not follow those 5 rights?
People who get hurt.
People can get hurt. Remember that NCSBN model, you know, protecting the public, protecting that client is our ultimate goal. Someone can get hurt, something could get missed, something could not get done that needed to get done. Is there one that you feel like you'll probably have a tendency to do, especially as we get going? I can probably guess. Do you feel like we'll probably under delegate as we get going? Yep. So it is finding that balance. You wanna make sure that you have enough time to effectively do your work while respecting other people's time as well, knowing that we're all very busy. Move this down. So questions about like delegation itself, like the act of it. And I will put these questions up on Blackboard for you guys first, as we go through. I have a lot of them, so I don't know if we'll get through all of them, so that way you have more practice. Any questions about delegation, like our rights, steps, like the difference between delegation and assigning? Just remembering that we retain accountability of that client. So in planning delegation of tasks to the assisted personnel, a nurse considers the 5 rights of delegation. Which of the following should the nurse consider when using one of the 5 rights of delegation? So which one would we consider? Which ones has our 5 rights?
Aren't 2 and 4 kind of redundant? I mean, if they have the knowledge and skill to perform the task, doesn't that imply without assistance?
Yeah, kind of is redundant there. Okay, so we know which ones would we not include for the 5 rights. So 3, we do the rapport with clients.
1.
And 1, we're not gonna consider their preference. So let's see in here. The AP has the knowledge and skill to perform the task. Will they complete the task without assistance? I think looking at that one, like the key difference, so 2 would be the correct answer. I think the key difference is knowing that they have like the knowledge and skills. Maybe just look at the little wording type of thing if we're doing like complex. This would be an example if I'd probably accept both those answers because they're similar. But the AP has the knowledge and skills if we're kind of pulling out the specific terminology that they use with our like 5 rights of delegation there. Another one, a nurse is planning to delegate a task to an assisted personnel. Which of the following actions should the nurse plan to take? So assess the AP's ability to follow the client's teaching plan, determine the social skills of the AP, evaluate the ability of the AP to work with peers, or provide a clear description of the task to the AP. What do we think? 4? Why 4?
Because providing a clear description of what needs to get done.
Yeah, so kind of looking at that communication as we're following our rights of delegation there. So if we don't evaluate the ability of them to work with their peers or determine the social skills, and the AP is not responsible for kind of that teaching plan and doing education with them. Alright, so a nurse is assisting a newly licensed nurse with delegating tasks to an assisted personnel on the unit. Which of the following statements by the nurse explains the purpose of delegation? So why are we delegating? So which ones can we automatically get rid of if we're thinking about like scope of practice and things like that?
4.
4.
3.
3 and 4. what's our purpose of delegation then?
One, two.
So 1 or 2, what are we thinking and why?
I feel like it'd be two,
Okay, why 2?
because it's still on your behalf, like they're helping you, but you're
Mhm.
still accountable for it.
So the correct answer would be 2. Like Bailey said, you're still accountable for the client here, so it is on your behalf. So you have a goal to get this thing, task or something done for your client, but you're asking someone else to do it for you. So you are still remaining accountable, so they're doing it on your behalf. And so like finding appropriate resources, provides appropriate resources. Yeah, it's ensuring that, they're getting the things that they need, but ultimately 2, it says permitting, you're having someone do that on your behalf. Alright, so. We have a leader of a team providing care for 6 clients. We have a team that includes the RN, an experienced LPN, and a newly educated assistant personnel who is in the 4th week of orientation to the acute care unit. Which client should the team leader assign to the LPN, LVN for nursing care under the RN's supervision? So we're looking at the LPN, LVN. So let's kind of walk through these. Mr. C, a 68-year-old man with unstable angina who needs reinforcement of teaching for cardiac catheterization scheduled this morning. Can we give that to the LPN?
Yeah.
And like you were saying, we can give it to the LPN because keyword here would be the reinforcement of teaching. That reinforcement education, our LPNs are able to do that.
Does the unstable make any difference?
So what's unstable angina? You guys remember back from perfusion?
Is it like a type of chest pain?
Yeah, it's a type of angina. So we have our stable angina, which is that predictable angina. It's gonna come on with stress or activity. It's gonna be resolved with that rest of nitrates. Where unstable angina, there's really no rhyme or reason to it. It's just chest pain that starts to happen. So that's kind of your, if someone has unstable angina, that's going to be their warning sign for that they're pretty much high risk for having an MI. So then they're gonna go down for cardiac catheter, they're having that unstable angina. So they're gonna go have that cardiac catheterization just to take a look and see what's going on and see if we need to put any stents in. But yeah, I can see how that unstable angina could throw someone off. So then we have Miss J, a 45-year-old woman who had a chest pain during the night and is now experiencing chest pain. She is scheduled for a graded exercise test today. What do we think? People shaking their head no. Why are you feeling like they would not be assigned to the LPN or delegated to? What was that?
It's new, because it says she is now experiencing chest pain.
Yeah, so having the chest pain over the night and now experiencing chest pain. So kind of thinking about it, and for thinking about that scope of practice, it's a change in that client and where they were at. 3, Mr. R, a 75-year-old man who had a left hemisphere stroke 4 days ago. Could you delegate things, assign the LPN to this? And why? What do you guys think? So why can we give that to someone?
It's been 4 days, so
Been
I'm
4 days.
stable now.
It's been 4 days. And so this is just an example too of not reading into the question, because it could be well, maybe they're unstable, or maybe they're not able to swallow, and we have swallow concerns, aspiration concerns. That would be reading into the question. So just remembering that what we have in front of us is the information that we know about that client. Miss S, an 83-year-old woman with heart disease, a history of myocardial infarction, and mild dementia. LPN be able to, and why?
Cause she's stable,
Yeah.
as of now.
She's stable. Don't have any change of status there. Mr. B, a 93-year-old newly admitted man from a long-term care facility with decreased urine output, altered level of consciousness, and an elevated temperature of 99.5 degrees. No. And why not?
Newly admitted. So we would have to do like the admission assessments.
Admissions assessment. How do we feel about their stability right now? Yeah, we're having decreased urine output, altered level of consciousness. We're having a little bit of a fever there. So yeah, we'd want to, so this is more unstable. So we'd be kind of wanting to be doing the primary care and doing what we can with them. And then Mr. L, a 56-year-old man with mild shortness of breath and chronic emphysema. What do you think? Say yes and no a little bit. See mostly yeses? Okay. And why?
Because if it's chronic, they're almost always gonna have some shortness of breath.
Yeah, so they have chronic emphysema. They're gonna have mild shortness of breath with that. That's going to be an expected finding with it. So questions about these ones I'll be working with. So which tasks should the nurse delegate to the newly hired assistant personnel? So asking Miss S memory testing questions? No, why not?
That's assessing.
It's assessing. So remembering when we're looking at the scope of practice, whether it be assigning, delegating, we wanna like look for those words that mean like, assessing. That it might not necessarily say assessment, but so then like asking those questions and memory testing question would be an assessment. Teaching Miss J about treadmill exercises. Nope. Checking vital signs on all 6 clients. Yep. Recording oral intake and urine output for Mr. B. Yep. Our techs can do, our APs can do our I's and O's. Assisting Mr. L to walk to the bathroom. And helping Mr. R with morning care. So these are all things that we've probably done throughout our clinical experiences or, you know, through work experiences with different people. Pretty straightforward there. So LPN LVN reports to the RN that Mr. R was unable to take his oral medications because of difficulty swallowing. The RN assesses Mr. R and finds that he is having dysphagia. What is the RN's best instruction for the LPN LVN? So I put down there, Mr. R is that 75-year-old man who had a left hemisphere stroke 4 days ago. So now having some difficulty swallowing. So what would be our best instruction for the LPN? So we have keep Mr. R in PO and I'll contact his healthcare provider. Try giving his medications with applesauce or pudding. Check with the pharmacy to find if they have liquid forms of Mr. R's medications. Or assess Mr. R's ability to speak and move his tongue.
I feel like it would be number 1.
Like number 1? Okay. Does everyone agree with number 1? So,
Well, can you call the pharmacy as an LPN?
no, pretty much all the communication. I mean, will be coming from the nurse, because remember, we're thinking about, yeah, we're maintaining that responsibility, so we should be following up with stuff, yeah. So, yeah, it should be us. And then even then, if they have liquid forms of Mr. R's medications, what's that all doing? So we order, even if we, is it going to address the issue of the new difficulty swallowing there? No. That's also changing the order for the medications, which as nurses and LPNs, you know, we can't prescribe or change those orders with it. Assess, we know that you can't assess. And again, two, you know, like 2 and 3, like if we're giving medications with applesauce or pudding, or even if we do get liquid medications, that's not addressing the underlying cause. Just kind of looking at that stem of the question, so have new difficulties swallowing. So 1 will be the correct thing that we would do. So we're gonna keep Mr. R MPO, contact the healthcare provider because we do have a change in status here for Mr. R, so we wanna follow up on that. Mr. C has returned from the cardiac catheterization lab and requires close monitoring after the procedure. Which procedures tasks would be best delegated to the LPN, LVN? Select all that apply. So check peripheral pulses. Check those peripheral pulses for us. So we've done our assessment. They're back, we've done all that. So can our LPN check the peripheral pulses? What do you guys think? Yeah. So it is correct, why can they check those peripheral pulses?
Cause we already did the assessment, like the main one.
Yep.
Or the first one.
We've done, yeah, that initial assessment as they come back, so we wanna communicate like when they should come to us if they're noticing changes in those peripheral pulses. Check the right groin area for bleeding every 15 minutes during the first hour. They're going ahead, they're lifting up the sandbag, checking for bleeding and putting it back. Can they do that? What do you guys think?
No. I don't know. I feel like no, but
What do you feel like no?
I don't know, I just feel like that's an assessment. Like an ongoing assessment.
So how's that different than 1 when we're checking those peripheral pulses?
So it's like that every 15 minutes, like after.
For the first hour.
So because it's that ongoing assessment, that's why you feel like,
Yeah.
okay. So we're having those ongoing assessments, would that be like reassessing? Yeah. Okay. So be like reassessing. What are other people thinking? Number 2, yes or no? We can come back to it, we can think about it. Continue IV fluids, normal saline at 50 mLs an hour. Okay. Assist client to the bathroom as needed during the first 6 hours after the procedure. So these are things, yeah, that the LPN can do. Administer morphine, 2 milligrams IV pushes needed for pain. No, because we already have the keyword there. That one would be IV. Then give clients daily multivitamin and stool softener. Yeah, we can do that. Since those are PO medications. So check. So we're kind of 2. What are we thinking here? So what are things that you would want to, if we're following those 5 rights of delegation, what are things that you would want to ensure with that LPN and LVN there? We're following those 5 rights of delegation here.
They can't continue the IV fluids, or they can.
Oh, so okay, sorry, I forgot to, so they can actually continue the IV fluids, it's just saying that they're just gonna be going. So they're not going to be programming the pump, they're just going to let them go. So again, it's kind of that wording thing there. And yeah, they can help clients to the bathroom, get them up and walking. So then I'm looking at 2.
I think the big thing that's throwing me off is during the first hour,
Okay.
because usually it's like the newer clients that are more
Mhm.
acute, and
Stable.
so I don't know, but I feel like they would be able to, because
Mhm.
it's like a reassessment,
Yeah,
but
So-
it is hard.
yeah, so they would be able to, again, that's where that communication comes in, of like, when do they need to come get you, if there's something going on. So the nurse would be in there, so ideally, the way it's supposed to go, now I'll ask you if you see this, when a client returns from a procedure or from surgery or anything, and they need to have those vital signs done, who should be getting the first set of vitals? The nurse. How many times have you seen the nurse get the first set of vitals when a client has returned? Yeah. It's normally, hey, like, tech, will you go get these vitals for me? I'll be in there in a couple minutes. So ideally, we should be the ones that are getting those first set of vitals, helping get the client settled, doing our initial assessment, and then from there, just these monitoring things, the LPN can do. But again, making sure that we're communicating, what we need them to report back to us and when, making sure that stuff's getting documented, following up with them, checking in with them. For following the 5 rights of delegation, they should be able to do that. But of course, if it's someone that's not experienced and they're, new, probably wouldn't be delegating that to them. Would maybe have them with you and show them and teaching them those skills as you're going through that. Discussion here. So we're caring for a client that has neutropenia. What tasks should the nurse instruct the UAP to perform? So we have our UAP. So select all that apply. So can our UAP take those vital signs every 4 hours for us? Yeah. So again, being explicit about how often we need those vital signs to be taken. Reporting temperature more than 100.4 degrees. And that communication, when do you need to follow up with me for things? Assessing for sore throat, cough, or burning. No, we wouldn't do that one. Our UAP cannot do assessing. Gathering the supplies to prepare the room for protective isolation. Yep, they can do that. They can get those supplies for us. Reporting super infections such as candidus or yeast. What do you think?
I feel like they would report, like, if they were helping, like, change them,
Okay.
and like smelled something.
Would notice something?
Yeah.
So they would notice something. And then, yeah, report it to you. And then practicing good hand washing technique. Something that we should all be doing, right? So yeah, you could always educate your UAP about, some of those, signs and symptoms of those super infections so that they can keep an eye on those as we're going through it to make sure that we are in fact protecting that client there. So it could, I'm just making sure that they have that education, but it could also go back to, the assessing too. It would be kind of like, the vital signs of like when they're like, oh, hey, like this is elevated. But if it's an actual assessment, they cannot do the assessment of that to know. Does that make sense?
So would 5 be wrong then?
Technically, in this scenario, 5 would be wrong just because they don't have that actual assessment knowledge to know how to do it. But I know through experience that, we all know what yeast is. So we're going through, or what it looks like in the mouth, or they're having a yeast infection.
So if it says reporting an infection or a specific one, it's gonna be wrong, but if it says reporting odor or.
Yeah, and changes, odor,
Like a change in status.
the elevated temperature, change in status, yeah. Since we have that specific knowledge as nurses with assessment to know what that stuff is. Does that kind of help?
Yeah, so if it says a specific disease state,
Yeah,
that would be a wrong answer.
yeah, since it's kind of more our scope of practice as nurses to be able to assess, so. Isn't it fun with all of little bitty wordy some things as we're going through here, so yeah, so assessing is technically within our scope of practice, and it's hard to sometimes like turn our brains off of like knowing like, okay, like as a tech, like I know how to do this, like just thinking of like just baseline scope of practice types of things, trying not to pull an experience, because if we're pulling an experience, that is the reading into the question where we can get into trouble with things. All right, a nurse is planning care for 4 clients and is assigning tasks to a licensed practical nurse and a UAP or assistant personnel. Which of the following should the nurse assign to the LPN? So complete an admission assessment for a client who has COPD, yes or no? No. So major INO for a client who has an indwelling urinary catheter. That's something that an LPN can do. Reinforce teaching to a client to begin taking enoxaparin at home following his hip replacement. Again, something that the that the LPN can do. And then develop a plan of care for a client who has cholecystitis. No. So we're kind of down to 2 or 3. So if we're looking at this, remember we have an LPN available and an AP. So which of the following should go to the LPN? 3. They can do that reinforcement education. Yes, they can technically do the I's and O's, but we have our UAP that is going to go do that. So again, looking at the team who you have available to you to be able to complete those tasks. But yeah, we as nurses, we can measure that I and O as well. Do one more quick. A nurse on a medical surgical unit is assigning tasks to a UAP. Which of the following tasks should the nurse delegate to the AP? So demonstrate the technique to instill eye drops? No. Medication administration outside of their scope of practice? Ambulate a client who has a cane? They can ambulate. So irrigate a wound? No, they can't do those dressing changes. Transfer a client to a stretcher. Record urinary output and record our dietary intake. So I think when we're working with these delegation questions, it's important just to make sure that we're following, knowing what the scope of practice is with the UAP versus the LPN. I think it helps that in the last unit we did kind of dive into that scope of practice, so hopefully you guys are familiar with that and more comfortable with that. I know the LPN is maybe what can trip us up a little bit, since that's a newer position than when we've had UAPs in the past. I think we're have worked with UAPs and are more comfortable with them. So I will post this to Blackboard just because there are more practice questions here within the delegation for you guys to complete here. So what questions do we have right now about delegation? Anything? Don't have any questions. We will not meet on Wednesday, and then just that time again to make sure that you're getting your capstone done. Making sure that you are taking that seriously, because that is NCLEX prep, doing those assessments, those quizzes, taking your time and actually making sure that you learn from them, since your plans are individualized to how you complete those assessments, or like what it is that you need to focus on. So then on Monday, we'll talk about communication, collaboration, and workplace violence. And so then that will be the last topic for this upcoming unit exam. So the next unit exam will be over leadership and management, delegation, and then communication, collaboration, and workplace violence. What questions do we have, if any?